Good afternoon, everyone. Please take your seats. And while you're getting seated, I wanted you all to please take out your phones. We are doing a poll everywhere survey, and Dr. Monica Harbell will be presenting later this afternoon. We'll present some of the preferences regarding both barcode and RFID, which were mentioned several times this morning for medication administration later this afternoon. Hopefully everyone enjoyed a nice lunch, and I am really excited about our next session, which will be led by Josh Lee.
Microphones. Hello, everyone. My name is Josh Lee, and I'm a nurse anesthetist and a member of the Stoelting Planning Committee, who's so grateful for the wonderful leadership of Dr. Rebello. Just like many of you, I'm passionate about patient safety, and it's an honor to be here as the moderator of our session, Medication Errors, the Patient and the Healthcare Professional. In this session, we'll start our discussion from the patient's perspective with Yvonne Gardner. We'll grow that perspective with that of the healthcare provider, from a nurse, an anesthesiologist, and an anesthesia resident, Toni Zito, Dr. Amy Vinson, and Dr. Amanda Milburn, respectively. And then we're going to progressively broaden our perspective as we think about its impact at a societal level, from Paul Lefebvre and Dr. Steve Greenberg. Once you've heard from our distinguished speakers, we'll then engage in a productive dialogue. So I look forward to this conversation ahead of us and everything that we're going to learn from it. Truthfully, I had one assignment, and that was to show you this slide while I said that. So here we are. And unfortunately, we can't fit all of their amazing bios on this slide. So we'll start with Yvonne Gardner, who has a video that she'll share. And I'll pull that up now. Arnie, I really want to make you proud as the millennial up here, but, or one of them.
Let me ask
Yeah. It's a YouTube.
Oh, there's a dot in YouTube.
Oh.
So you just copy it and paste it and take the dot out.
You get to that. Paste the dot.
Great.
5 words you pronounced wrong 2 years before.
Thanks, Josh. Yeah, sorry, that's hard for me to watch, but. So as you can see from the video, my son Parker, he's greatly missed by a large family, a large community that felt his loss from day one. He was a very vibrant young man, healthy. And to tell you a little bit about his background, he just newly been married and he snored. He snored like a freight train. Even when he was young, our bedroom was up above his and we could hear him from the basement. When he'd get home at night, we could hear him. And so after being married for a few months, he decided on his own that he was going to go in, and his doctor's advice was to have his tonsils out and his adenoids, to stretch his sinuses, see if maybe that would help his snoring. So the same day he went in with his wife, I took my 17-year-old daughter in to have her tonsils taken out. They were very inflamed and causing her a lot of pain. And so we kind of crossed paths at the hospital that day. My daughter was first. She went for the surgery with the same surgeon, had her tonsils out. We took her home, got her situated. We heard later from my daughter-in-law that that my son was home and that things went well. And I heard from him the next day. Things were fine. My daughter was still miserable on the couch, taking her medication as often as the doctor had prescribed it to her. And Saturday came and my son and his wife came by, and this was December 3rd, dropped us off our kilo Christmas presents. And just remember thinking, wow, they're on the ball. I haven't even thought about Christmas yet. It's been a busy season for me and I hadn't even thought about Christmas, but they're already delivering their Christmas gift. They gave us a hug and told us they loved us, and then went on their way delivering the rest of their Christmas gifts. Went home that night and put up their first Christmas tree in their little apartment. And Parker, he had all of his Christmas gifts ready for his new wife, and he wrapped them and spent the evening there with her. The next morning, I was sitting at church with my family, and I got a call from my daughter-in-law, and she said, Parker's not breathing. And I'm like, that was just a weird thing. I'm like, well, did you call an ambulance? She said, yeah, the ambulance is already here. You guys need to come here. They were only about a mile away from where we were at. And so I had left the meeting to answer the phone call, and I went in and got my family. It was a very cold December day. It was like 20 degrees outside, and we went to my son's house. And they, first of all, wouldn't let us in. They said it was a crime scene, that he had overdosed. I was very angry with the police officer. We live in a small community, and I knew that police officer. And I'm like, yeah, not this son. He wouldn't have overdosed. He was my child that wouldn't even rarely take Tylenol or anything for a headache. He was the kind, he's like, no, Mom, I'm just gonna go lay down for a while. I'll be good. I'm just tired. So I knew that that wasn't the case from the get-go. So after standing out in the cold for a few hours, they finally relented and let us go inside. They'd already taken my son's body and put it in the body bag. But I insisted as his mother, I wanted at least to touch him and still feel that somehow he was there. But come to find out, later we did send him in for an autopsy to find out what could have caused this. The law enforcement told us, and Even some of the medical community just said, oh, this is just a weird firestorm of events, and sometimes these things happen. And how does that happen? That a 21-year-old perfectly healthy young man can go to sleep at night, lay next to his wife, and not wake up. She got up early that morning because she knew he wanted to sleep, being in pain, and she'd been up talking to him in the middle of the night, about 1 or 2 o'clock. He asked for another pain pill. His doctor had prescribed him Percocet, and they laid in bed and talked, and she got up early and then went back in there a couple hours later and found that he was unresponsive, not breathing. And so that's when she called 911, and my son's a big man. He's 6'5". He was about 230 pounds, and she was little, and she was trying to get him on the floor to give him CPR. And then when the EMTs arrived, they just said, no, there's some liability there. It's too late. There's nothing we can do to help him. And that was about the time that we arrived. And so as a mom, I was surprised that how could I send my son in for just a routine tonsillectomy and not get him back. But it was because we didn't know of the dangers of the medicine that he was taking. I had no idea as a mom. Of course, I tried to do some due diligence, and I searched on the internet to find tonsillectomies and any kind of problems or things that could happen. And I really didn't find much. And it was after my son passed away, then I Googled tonsillectomy fatalities, and a lot of things came up. But I still didn't have the reason that my son had died. I didn't know what had killed him and why he had died. We waited 6 months for the coroner to come back and tell us that he died of pneumonia. And his ENT said, no, he was perfectly healthy. Nothing was wrong with him when he came into my office. That was not the case. And when we started researching, he said that he believed it was respiratory depression brought on by the opioids. We were able to we had a good list. His wife had kept track of the prescriptions that he had been given the whole time since he'd returned from the hospital. And even being such a big man, he'd only taken half of his prescribed dose of the Percocet for the pain. And my little daughter, she was 130 pounds, and she'd been taking the full dose, and it didn't affect her as it did my son. So this is, looking at medical professionals, the ENT was my friend. He was our friend. I knew he wouldn't have done anything to purposely injure my son, which he didn't. The surgery was fine. Everything was fine. But it was just a prescription, and it was that opioid. And myself as a mother, since that wasn't something that was familiar to us, we did not understand the complications and problems that could bring on. And so as part of my story, I just wanted to thank you guys for all that you're doing for patient safety. When I was looking for my son to find answers, I got such a wide response from our community because Parker was well known. And so I started getting all sorts of texts and messages and phone calls saying, well, didn't you know that this little 3-year-old died like this a few months ago? She had a tonsillectomy and she died. And I didn't know about that. And then I had a girlfriend I went to high school with, and she said, yeah, one of our truck drivers, he went in for tonsillectomy, he's 28, and his girlfriend went to check on him a couple days later, and he was dead in bed at home. There was an older lady that was my neighbor, and she said, my daughter, she went in for a tonsillectomy, and a couple days later, she was laying on the couch, and her daughter found her unresponsive, and they called an ambulance, and she was able to be resuscitated, and she survived. A young lady that I coached in basketball, she had contacted me on Facebook, and she said, yeah, I had the same thing happen to me. My husband was he was setting his alarm and giving me my medicine every 4 hours. But with her second dose, after she came home from the hospital, he came in there and found her unresponsive, and she was taken to the hospital also, and she was revived. But a few months after, my doctor he worked hard, and I can kind of understand some of your frustration. He was kind of ostracized by the physicians that he worked with after the death of my son, because he knew that there was something else that they could do as a medical community. So he started sending home monitors with his patients to monitor their oxygen levels. Because he says, we're keeping them on monitors when they're in the hospital, and then as soon as we release them, we send them home. We send them home with these painkillers, and they're not being monitored. And they're with people like family that aren't educated or aren't taught what type of signs to look for. So one of the little gals he sent home with a monitor, she was realizing, and her mom, that it was dropping to 70 on her pulse oximeter, but they still didn't understand what that meant. And her mom said she last saw her about 3:45 in the morning, and it was, her oxygen monitor was dropping down to 70, but it wasn't an alarming one. And then her mom would just kind of shake her a little bit, say, take a deep breath, take a deep breath. And then they both fell asleep. And then at 4 o'clock, she woke up and her daughter was totally blue, flatlined, not breathing. And I met this young woman later. I didn't know her before this. She was able to tell us that when they were trying to revive her, her sister, thank goodness, knew CPR. So they started CPR on her immediately. And she said she could come back for a little bit, but she could not respond with the way the medication affected her. She could not make any kind of response. They were yelling at her, saying, just blink your eye, finger, do anything so we know you're still there. She said she could hear them, but she could not respond. And they ended up giving her 7 doses of naloxone before she made it to the hospital to be able to keep her alive. So as far as Parker's story, this is something that was unknown to us, and we didn't know it was an issue. And I know in the medical community, you've been more aware of it than we have, but I totally appreciate what you're doing for patient safety, little things that affect all of us. Because just with Parker alone, it's not just one patient that you lose. It affected numerous people in our community, his friends. A lot of them had major depression issues after that. He was a good leader for them, and his siblings struggled and had a hard time trying to understand how this could happen to their brother. But I just want to thank you guys for all that you're doing for patient safety. Thank you very much.
Yvonne, thank you so much for your bravery, and thank you for reminding us the human component of why we're all here. Next up, we have Toni Zito talking about recovery and the recovery room nurse.
Thanks, Josh. Thanks, Yvonne, for sharing your story. I can probably vouch for everybody in this room that nobody goes to work with the intent of doing harm. And when that happens, it does take a toll on everyone. I am a registered nurse in the PACU at a major healthcare system in Cleveland, Ohio. I sound like a contestant on Wheel of Fortune. I am not speaking on behalf of the Cleveland Clinic, but I am employed at the Cleveland Clinic. And I have been in the peri-anesthesia setting for 40 years. It's a big year for the 40 years celebration. I began speaking on opioid safety prior to the pandemic, when we realized we had a problem in our hospitals and our community, and it was very prominent in the news at the time. I chose to work at the hospital that I'm at. It's a regional hospital of the Cleveland Clinic because it is in my community. It's in my community, it's in my neighborhood. I serve my friends, my kids' friends, my patients. I know, I see them at Target, I see them at the store. So when this was coming to light, I was fortunate enough to be approached by 2 of our anesthesiologists, Dr. Mark Taylor and Dr. Eric Chang, that said, we need to take this education out and awareness out to our caregivers. Well, within the Cleveland Clinic health system, we were able to touch thousands and thousands of caregivers talking about opioid safety in perioperative settings. So then 2020 came, we spoke nationally, we went to communities, we did I thought a really good job of raising awareness about opioid safety. And we didn't really just talk about opioid use and misuse, but we did talk about the dangers of using opioids. And what I learned is that nurses play a critical role. In the PACU, we can always find nurses vigilant at the bedside, and we can always blame the system. But I came to realize that I, as a nurse, am part of that system. So what was I doing to change my practice, to protect my patients, to prevent harm for my patients, when our everyday use of opioids was so high? When I was an educator prior to this role, and when we orient people, one of the hardest things to teach a nurse coming from even an ICU setting or a med-surg floor is the amount of pain medication we give in a short period of time, in divided doses, and it's a lot to wrap your head around. We do over in the enterprise 250,000 surgeries a year. That's a lot of pain management and a lot of medication. So, oops, sorry. Let me see. So I promised them I wouldn't show graphs, but this is my favorite graph in the whole world. It's a graph in 2022. It'll probably be the same graph in 2023 from Gallup. We've only fallen off the top spot, nurses, once, and that was in 2011 when the firefighters took our spot, and rightfully so. We are the most trusted profession, and with that comes a lot of pride, and I feel a lot of responsibility to prevent harm and to do what's best for our patients. So when we talk about attributes and skill sets that nurses have, we always look at the technical skills, the clinical judgment, the assessment skills, the ability to do two things at once, which we know is not always safe. Just being versatile, being able to, I can start my day in pre-op, we're all cross-trained, I can go to post-op, I can send patients home, I can take the ICU patient. Those are all really good, valuable skills. But the one that's least mentioned is the one that I feel is the most important, and that's the role of advocacy. When a patient enters the healthcare system, especially today, you need a navigator. You need someone that's going to speak for you when you can't speak for yourself. If I work pre-op, there isn't a day that goes by that a patient, and we see a lot of patients, would say to me, please don't let anything happen to me. And I assure them they're in a safe place, and I do my best to advocate for that patient. But I am conflicted. Remember that at the same time, I have an ethical responsibility to manage their pain. That's from the ANA, that's from our nursing, that's from our soul. We don't want to see people suffer. So how do we weigh that responsibility to manage pain and the dangers of pretty much what we're doing to do that? There is nothing I want to do during my time with that patient to betray that trust. We didn't get that top spot, and I'm not boasting. We did not get that top spot because people don't trust us. So if I have a recovering addict come in and he says, I really, really don't want anything that's going to show up in my drug screen or put me back on that path. I work really hard with our anesthesia team. I work really hard with him or her surgeon to kind of come up with a plan. Does it always work? I have the same frustrations that you do. What do I do in the moment? It's really hard. It's episodic care. I can't follow that patient all the way home. So some of the challenges I face as a peri-anesthesia nurse is the limitations of the pain assessment tools we have. We know the gold standard is 0 to 10. We know that my order sets are then accompany that, and I can only give pain management in the state that I practice. I can't go off those ranges. I can't say, well, I think Tylenol would work here when I have an order that reads, if the pain is 0 to 4, you must give. I can work with that and try to get another order and do what I need, but that is a limitation of the pain assessment tools that we have. I don't believe that the risks of opioid administration are communicated to our patients. I have friends that work in oncology, and you better believe before you start a chemotherapy plan, you are given every risk and benefit before you start that medication plan. And you're usually counseled by our pharmacist. I don't think our patients know. In one study, they showed that like a third of the patients did not even realize that what they were taking were opioids. We are under the same production pressures and clinical workload that all of us in this room are. We're asked to do more and do it faster. I never intend, and I apologize all the time, to put the OR on hold. We never intend that. But we have a workload in that room, and it's like a throughway. It is people coming and going. I'm trying to do all this in a very distracted environment, and yet I'm very aware of the throughput of trying to get out of the OR so that the other people can get in. And that's the environment which we work. I may only have 2 patients. We have, our professional society has staffing guidelines. I should only ever have no more than 2 phase 1 PACU patients. And I'm proud to say I work in an institution that they hold us to that. But even managing 2 people at the same time is difficult. I also have standardized order sets, which I'm sure everybody does. And it solved one problem and kind of created another. We don't really customize those order sets per patient. And sometimes I don't advocate for that as well. There is a lack of education in pain management for medical professionals, and I'm going to say for nursing. I did not get any, and I trained a long time ago, but I also taught nursing. We teach pain management about this much, and we don't do it well. I don't know, in the area of anesthesia, you may have much more robust training, but it's usually by experience and trial and error. And then we don't have a way to manage our patient expectations. We all see what patients are exposed to. They're a little more aware of the risks of opioids, but they don't really know what their options are. And if nobody's offering them other options, opioids seem to be the easy choice. We have lack of consistent standards and guidelines and equipment for monitoring. We have position statements. I don't even want to talk necessarily about capnography. My colleague and I just authored a position statement on the use of capnography in the PACU, but we're using words like consider. We don't have you must, and sometimes nurses would like you must, then we can follow that. And then how do we treat, coming out of this addiction or still living in it, how do we treat patients that are recovering addicts? We don't really have a lot of science that tells us the best way to do that. Sometimes, unfortunately, we don't even know that that's part of their history until they present for surgery. But I don't want to only talk about the challenges. We have done great things in the area in terms of medication safety and error prevention. There's legislation that has helped us. There's right sizing prescription guidelines. I always tell the story of a resident that was in my carpool. So I'm a little bit older, and he was an orthopedic resident. And he was sending my 90-year-old patient home with a wrist fracture with 90 oxycodone. And I felt comfortable in the moment to say, Kevin, what are you thinking? What are you thinking? I don't know. They said, do this, do that. You know, he's managing his workload. But if nobody questioned it, that lady would have walked out the door with that prescription. And then we know that those extra medications are ripe for misuse. Safe medication disposal programs, we have those in place now. Part of my research was sending every patient home with an opioid disposal bag that, in following up with them 30 days later, the results were abysmal because people weren't willing to part with it in the time of limited prescribing. We have opioid-free anesthesia. We have different techniques we can use and offer the patient. And we do have some consensus statements and guidelines that guide us. Barcode medication administration. Thank you, ISMP, when I was an educator, we fought, everybody said the PACU, it's too busy to do barcode medication administration. We give a ton of partial doses. I manage those 2 patients. I may be medicating them at the same time. I love barcode medication administration. It's a layer of safety for me. And when nurses train under that in different divisions and they come to the PACU and we didn't have it, we really removed a layer of safety that needed to be there. We have pharmacy collaboration where I work. We meet regularly with them. We talk about what our concerns and our problems are. We have EPIC, and one thing in the system is we could not release our medications until they arrived in the PACU, and then we had to wait for pharmacy to verify them, and that sometimes took a little bit of time, and we'd have a patient that was screaming in pain. So we worked on that process to correct that. We removed compounding and mixing at the bedside based on ISMP guidelines because we were mixing our own ephedrine and neo from an IV bag not too recently. I should have been concentrating on supporting a hypotensive patient, not mixing medications. We've changed all that. So there is good work being done. And if a medication error is made, I work in a place where I am very safe and I feel very supported. And we have peer support programs. And I'm really proud of that. People are not afraid to talk about them, but I'm not sure what constitutes a medication error. Is a medication error, Paul will talk about it maybe in a legal sense, but is it omission? Is it because, am I giving opioids to someone that does not know the risks and benefits and then probably sending them home with them? Without necessarily any monitoring? Am I giving them things that can cause harm down the road? That's where I struggle. And in a fast-paced environment where we need to keep moving and we have that inherent pressure to do more and do it faster, is it easier to give an opioid than sit at a bedside? Probably. Do I have to do everything I can to maintain that patient's trust? Absolutely. Thank you.
All right, folks. Next, we have Dr. Amy Vinson with Burnout and Medical Errors in Anesthesiology.
Good afternoon. Is everybody still awake after the postprandial coma time? I can't thank you guys both enough for the perspective you offered. It takes a lot of courage to get up here and talk about something as personal as that. A lot of courage, and I'm overwhelmed, to be honest. You know, this is our day-to-day medicine. We take that for granted a lot, but our day-to-day can be really, really hard sometimes. We can bear witness to some of the most unfair situations imaginable, like Yvonne's son. And, you know, it's deeply humanistic what it does to families, what it does to us. I'm going to talk about burnout because that's a really, really easy aspect of humanism to measure. But please know that when we talk about burnout, it touches on moral injury. It touches on sadness. It touches on disengagement. It touches on all these other aspects of who we are as people. And how we bring that to our practice of medicine. I'm going to take a brief step back to define burnout because it's such a ubiquitous term in today's parlance. Merriam-Webster describes it as exhaustion of physical or emotional strength or motivational. So it's very multifaceted. It's not the same for different people. And it's usually at the result of prolonged stress or frustration. It's not the same thing as stress. It's not the same thing as frustration. We all chose stressful careers because we enjoy them. There's nothing wrong with stress. It's when that stress is too big, too frequent, it's unmitigated, and we don't get to recover in between. Since we're going to be talking about measuring The most common metric to measure burnout is the Maslach Burnout Inventory. It was developed in 1980 by Christina Maslach and our colleagues in California. And it looks at burnout as an aspect of 3 domains, basically. This idea of emotional exhaustion, you just got nothing left in your tank to give to your next patient, to give to your family and friends, or to give to yourself. A low sense of personal accomplishment or a feeling of inefficacy, this idea that you're not appreciated for what you're bringing to the table, or you're not really making a difference. And depersonalization or cynicism. That's a big one for us. We depersonalize as a mechanism of our workflow. You know, you're taking care of the lap chole in room 5. You know, that's depersonalization. There's nothing wrong with it unless you're routinely using it as a coping mechanism. So for me, it's my big early warning sign that I'm getting burned out when I start making sarcastic jokes. Other people may think it's funny. Other people are laughing along with me, but I recognize it's a red flag. I need to take some steps back. When we talk about this metric, if you have a threshold level of emotional exhaustion and or depersonalization, most people classify that as being, quote, high risk for burnout. In the studies that I'm going to show that our group did, we also discuss a more severe subset called burnout syndrome, which is kind of in line with the World Health Organization definition, which basically means you have reached a threshold level of all 3 domains at once. I'm going to talk about anesthesiologists, attending anesthesiologist research. There is every reason to believe that much of this data is extrapolatable to nurse anesthetists, to nurses, to medical students, to other members of the healthcare workforce. But in 2021, we published the result of a survey that was sent out by email in March of 2020. I don't know if you remember March of 2020. Probably the poorest planning for survey timing you can imagine. But that's when we did it. That was when COVID had not yet reached our ERs for the most part, but they had definitely reached our inboxes. So we were happy to have a fairly robust group of survey respondents. Nearly 4,000 US attending anesthesiologists, members of the ASA, responded to this survey. And we found that, along the same lines as other physicians, we had emotional exhaustion, depersonalization, and a low sense of personal accomplishment. 59% of respondents were at high risk for burnout, and 14% were burned out. So what? That's just a number. What mattered to us were the other 13 questions based on demographic and practice factors that we asked, and what was their association to burnout. Now, without getting too much into the weeds, we did a multivariate regression analysis looking at which of these factors impacted or was associated with, I should say, being at high risk for burnout or having full burnout syndrome. And what you'll notice about this multivariate regression analysis is that you've got like your smattering of factors that fall along the odds ratio of 2 line, things like not having a lot of support at home, being in the LGBT community, working full time. And then there's one factor that just jumps off the page, and that's espousing little to no support in the work life. If you say you have little to no support in your work life, your odds ratio of having high risk for burnout is about 7, and it's 10 for having full burnout syndrome. That's massive, to the point where there's several hospital systems that now use this as a snapshot picture to see where I like to call it gross departmental morale lies. And so where are we right now? How supported do you feel? Obviously, that's the beginning of a conversation and not the answer, okay? After 2021, some things happened. Well, we had a pandemic and all that came with that, both to our professional lives and our lives in society. We, for the first time, probably worried how we comported ourselves at work was a risk factor for our family's health when we came home. Were we exposing our families? We didn't have the same support structures that we did before. We couldn't socialize in the same way. Many people were quite isolated during this period of time. We couldn't shop the same way. We did things completely different. We dressed differently. We looked different at work. In addition, We had an incredibly contentious political period that continues to this day. That is a stressor. That is a strain on the system. We have had a national reckoning, long overdue, about racism and systemic injustice. There's a lot of stuff that's happened. A lot of, as I would say to my 9-year-old son, a lot of big feelings. Okay. So we repeated this study in November of 2023 or 2022, excuse me. And we found that everything kind of worsened. And this is in line with what we've seen from other physician groups. It has come down in those physician groups since this time. We have not yet repeated this one again, but everything kind of went up. Again, these are numbers. This is not what you came here for. We asked some more questions and we got some geographic information here. There's certain hotbeds of burnout that are important to know about. And what are we doing with that information? Well, the first step I took, as I'm chair of the ASA's Committee on Physician Wellbeing, I specifically looked for applicants to the Committee on Physician Wellbeing from this dark blue area, so I could get a little bit more representation into what is going on there, what's modifiable, what's leading to this. Again, it's the start of a conversation, not the answer. We looked at it based on what is your subspecialty in anesthesiology. This is my personal recruitment tool to the field of pediatric anesthesia, if anybody's interested. But critical care certainly bore the brunt of the pandemic, but nobody's immune, and it really does fall out that everyone is still at fairly high risk to this day. We looked at changes to plans in working. Has COVID accelerated your plans to actually retire? Accelerated them. Nearly 40% of people said it accelerated their plans to retire. That's significant. This is a snapshot in time, but when we said, how likely are you to leave your current job in the next 2 years, 35% of respondents said they're likely or very likely to leave their job. These are attending anesthesiologists in the US. 35% say, I'm likely or very likely to leave my current job in the next 2 years. That's a lot. And how many have reduced their employment status? 25% had already reduced their employment status through the pandemic. And then, let's see. Oh no, that was the one, if you plan to do so in the next year. Excuse me. So 25% had either done so already or planned to imminently. So it's probably already in the works. When we asked, what do you think is going to help? The number one thing is staffing. Raise your hand in this room if you currently have staffing shortages in your place of work. Okay, staffing shortages is why I couldn't come to the thing last night. But adequate staffing is the number one thing. Okay, when you ask people what's going to make your job better, 9 times out of 10, the first couple answers are money and time in some kind of combination of that. But when we ask this group of people what's going to make your life better, their first 2 answers are adequate staffing and better morale or culture, and then money and time. But it is significant that the top 2 things have nothing to do with money and time. It has to do with resources. Give us what we need to do the job we came to do, and do it safely. Same thing. If you said you had little to no support in your work life, your odds of having burnout or being at high risk for burnout, astronomically higher. So what is it about this job that is so hard? We've heard some of it. We are human beings who are very intelligent, who are very hardworking, who are very resilient people, who have chosen a career to dedicate our lives to, so that we can build a skill set to bestow a very specific and highly skilled form of kindness on our fellow man. And when that doesn't go right, it hurts. That's what it boils down to. That's why this job is so hard. We pour our heart and souls into it, and sometimes it goes sideways. Miracles aren't always easy. We love to compare ourselves to the airline industry, but we are not the airline industry. When the miracle on the Hudson happened, every member of that crew, and that was a miracle. I mean, nobody was killed. Nobody was seriously injured. Everyone on that crew, including the control tower, was mandated time off and had to have a psychological evaluation before coming back. That is not how we handle miracles. We pull off miracles all the time. And sometimes they're really hard on us. And I can ask you, if you're waiting for your flight to take off and you go up there and Sully Sullenberger's there and you're like, wow, the Miracle on the Hudson guy, right? You spoke at the ASA. But if you go up and you look down and his shoes are still wet from waiting off his plane in the Hudson, I bet it would give you pause and you'd wonder, are you in the right frame of mind to be working? And I bring that up because, again, we are not the airline industry. We have to work with wet shoes a lot. And we need to understand how that impacts us and how to support one another through that. What is the normal response after something going really badly, after a medication error, an adverse event, perioperative catastrophe? Sue Scott is an incredible nurse educator. She did this study where she asked people what was their process of recovering. And I love this table because it's everything. You can have physical symptoms of hypertension, tachycardia, not sleeping. You can have all sorts of psychosocial side effects. You can have grief, remorse, worrying about your reputation, not wanting to go in the same room again, being mad, all sorts of emotions. They're all fairly typical after a major event. When we asked anesthesiologists, that's my cue, I got 2 minutes left. When we asked anesthesiologists about perioperative catastrophes, most of them required time off. Most of them required time to recover from the event. 1/5 of them never did. And a lot of them considered leaving the job entirely. But what's amazing is that 2/3 said that the care they provided in the next 4 hours was compromised. They admitted to being an impaired clinician. At that time, only 7% were given any time off. We're hoping to repeat that study for anesthesiologists this year and maybe even bring in nurse anesthetist in that process, which would be lovely. I'm going to pause over these. Just want to give the other speakers time, but if you take nothing away from my time, it would be this. Again, we experience extraordinary human events on a fairly frequent basis. After those events, whatever you are feeling, however you are responding, it's okay. It's normal. It is normal to have normal human responses to extraordinary human events. That doesn't mean you don't need help. It means that you're okay. All right? So if you remember nothing, remember that. Thank you, guys.
Dr. Vinson, thank you. Okay, next we have Dr. Amanda Milburn speaking on medication errors or resident's perspective.
So I guess I'm going to become a peds anesthesiologist. But good afternoon, everyone. My name's Amanda, and I'm honored to be here today. I have no disclosures to report. So let's rewind to the beginning of your training. Back in residency, CA1 year, mid-July. You arrive bright and early to your OR to set up the room. The MS MAID's mantra runs through your head as you rummage through the Omnicell drawers to find exactly what you need. There's a lot going on at once. You just moved to a new state or a new hospital with a new EMR system, with people you don't know the names or titles of, and most of all, with equipment and medication you've rarely, if ever, used. What is a nicotine? And Robenol is part of what drug class? How am I supposed to know that TXA is supposed to be diluted into a 100 cc bag and infused over 10 minutes rather than a rapid IV push like all of our other medicines? How about on OB with Methergin? That's typically given IM, not IV like all of our other medicines. So you open up your medication drawer to find, as was previously mentioned, all of these look-alike vials. As we know, anesthesiology is a unique specialty in which we are our own sole checks and balances. On a daily basis, we have a multitude of medications readily available at our fingertips, not needing an order, pharmacy's approval, or nursing verification prior to administration. My healthcare system is a charity, small-scale community hospital in which we do not have the luxury of barcoding systems. In our Omnicell drawers, given all of these look-alike vials, they're easily mixed up.
Today, I might find neostigmine in a brown bottle with a yellow cap at 0.5 milligrams per milliliter, whereas I might go to my next hospital tomorrow and find neostigmine in a clear bottle with a blue cap at 1 milligram per milliliter. So not only these different drug vial, how they appear, but also their concentrations. And again, like has already been mentioned, this has been an ongoing issue, especially because of the drug shortages. So in preparation for this talk today, I met with my patient safety officer, department chair, program director, and numerous attending anesthesiologists to give you real life scenarios of where residents can go wrong. Though I was not personally involved in any of these scenarios. So first off, you're new to the OR environment and you're not up on all the hip lingo that your colleagues speak of. With this mindset, a resident was in a carotid case and was ready to reverse neuromuscular blockade with neo and glyco. But not the neo you're thinking of. The resident pushed neosynephrine. The blood pressure went to the 300s over 150s and the patient began bleeding from the carotid. This emphasizes the need to ask questions, to avoid abbreviations, and to never assume. The only assumption you can make is the fact that the person you're speaking with knows nothing. As such, this topic of level setting in teams is extremely important and something that I want to highlight, which should definitely be emphasized and facilitated more in faculty development, especially at academic institutions. So the next case is on IV fluids. I was just talking to another colleague and she says this happens at her institution as well. A trauma patient comes up to your OR in the middle of the night, almost midnight, and the patient arrives before you even have time to draw medications. An arterial line is placed and the case proceeds uneventfully. You got through the thoracotomy until you hand it off on the ICU and the ICU nurse realizes the arterial line bag is spiked with mannitol rather than normal saline. So this picture here highlights how mannitol can be with the blue font, black font, and how similar it is to our NS and LR that we typically use. Although there is no apparent harm to the patient presented, this emphasizes the need for larger system change. And hindsight proves this was a great opportunity to use the HRO principles of stop, think, review, act, and review, STAR, with each and every step that we take. So moving on to OB, the next case, we're taking a patient with a laboring epidural to C-section. We love those, right? In the OR, medications were drawn up by a chief resident and labeled appropriately. After bolusing the epidural for surgical analgesia, the patient starts seizing. Initiation of general anesthesia with intubation, followed by an ICU admission, occurred. Later, it was found that ANSEF was inadvertently bolused into the epidural rather than the lidocaine. After a root cause analysis, we no longer have loose ANSEF vials on L&D. Instead, we mitigate this with ANSEF attached to 100 cc bags, like we said TXA should be in, for infusion. Another possibility to minimize such error is to introduce non-Luer lock systems to prevent wrong site administration and minimize erroneous cross connections, especially in a place with beginner learners such as in residency. Of note, this patient made full recovery and even in fact chose to come back to our hospital for her next delivery, which was uneventful. Keeping with the OB theme, there's another medication error where a resident went to go pre-hydrate a patient and opened up the fluids wide, took it off the IV infusion pump and heightened the IV pole. Only later did they find out that this wasn't just plain LR. It was LR mixed with Pitocin. So many of these types of errors will go unreported. However, it's extremely important, as we've been speaking of, that trainees initiate conversation, be transparent and open, allowing others to learn from these medication errors so that we don't repeat them. As was mentioned, we must provide emotional peer support to those healthcare workers when errors do occur. And for the attendings in the room, I'd like you to think of how you react in a scenario when a trainee makes an error. What tactics do you employ to foster a learning environment rather than a punitive one? And I know you guys probably are doing a great job, but my attendings need to hear. So the next case scenario is in a vascular case. An older surgeon, which when talking to attendings, they were like, how did this even happen? I didn't know that was a thing. An older surgeon asked for heparin in milligrams rather than units. The resident gave the number asked for in units, and the patient got markedly underdosed and ended up ended up thrombosing. As we know, closed loop communication is key to preventing these errors, and it could potentially have, corrected itself in real time. Heparin is notorious for these issues, given all the concentration differences listed here, and there might even be some more. A similar case, well known to pop culture, is Dennis Quaid's twins, who each received 1,000 times the recommended dose of heparin, not only once, but twice in 2007. We must also hold the pharmaceutical companies accountable as a contributing part of this problem affecting patient safety. And thus, this isn't just a resident's fault. Last case scenario, I'll run through one more case where the resident was taking care of a patient with an intracranial bleed. The attending actual program director left the room knowing that the patient was hemodynamically stable, until a few minutes later, they were rushed back into the room for extreme hypertension and uncontrollable bleeding in the surgical field. Although the resident never admitted to it, they realized or hypothesized that the resident must have bolused a medication through the norepi line, even though the attending thought that that was off. This had significant patient impacts to both the patient and the surgical field. So in summary, the medication errors I just reviewed with you all lacked at least one of the 5 rights, which ensure safe medication practices. Remember, there's always a human behind each syringe, hence why so much of this conference has been discussing ways to better prevent these errors, to ensure that we have the right patient, right drug, right dose, right route of administration, and given at the right time. So next I'll go into some factors that allow the opportunity for error to occur, especially relevant to residents. So my program we still have 24-hour shifts. We do not have a night float system. So it's been proven many times over that sleep deprivation or fatigue negatively impacts critical thinking and decision-making. In addition, nutrition, hydration, and recovery are all key components, especially in a 24-hour day, to combat cognitive performance deterioration. As was mentioned, as acute care physicians in anesthesiology, we make quick decisions at critical moments. Our scope of practice includes care during catastrophic events, such as massive hemorrhage, trauma, cardiac arrest, and devastating neurologic emergencies. On top of this, we also are typically siloed in our ORs for, if not the entire shift, which makes it very hard for in-person social connectedness within the department. Work conditions we can all relate to. This is not just relevant to residents of high stress environments, treatment complexity, lack of standardization in the ORs, lack of error alarms because we're able to bypass those soft constrictions. Drug shortages we mentioned, dim lighting in laparoscopic rooms, we just have that one clicky button. And not having the necessary drug labels. So at my institution specifically, one of our training sites, we always have the green atropine label, 0.4 milligrams per milliliter, yet that concentration is never available. It's always atropine at 0.2 milligrams per milliliter. So why is that there? Moving on to organizational culture, we have multiple training sites. We go from my program, 3 different hospitals with not only different EMR systems, but also different drug concentrations. And we have the luxury of having multiple attendings from different backgrounds and different specialties, but that means different stylistic preferences. Some like diluted opioids and some like straight from the vial, which makes it very confusing for the resident to remember if the syringes are not labeled appropriately. In addition, in a multidisciplinary OR system, that leads to hierarchical culture, which then leads to intimidation, fear of subordination, and imposter syndrome, which can discourage junior members of the team from speaking up. I'm sure we're all familiar with the production pressures, and that can get overwhelming, but should never compromise patient care. When all these competing factors, both organizational, workplace, and personal, interfere with productivity and concentration, they can have detrimental effects on patient safety and outcomes, team communication, job satisfaction, and employee well-being, just to name a few. In the interest of time, I'm not going to go into my QI project, but happy to talk about it later. This is one way that I've tried to improve patient safety at my institution, and will continue to do so happily at the implementation stage, and look forward to seeing the results. These were our top goals from the program. And ultimately, I'll leave you with this quote. I'm incredibly honored again to be here today to meet so many of colleagues that I've never met before, but also we have the same interests, and I've found so many similarities already. We know that medication errors are the leading cause of morbidity and mortality, and investigation and transparency are key to change. Work done by the APSF and all the members of this audience can break down these barriers and tackle this challenge together. As you think of your impact and spark for change, think you can pick up a mistake and carry it as a burden, or you can set it down and use it as a stepping stone for greatness. Thank you.
Dr. Milburn, thank you so much for your words. I think that would make a wonderful episode for our APSF podcast. Relatable by all, but especially our learners. So thank you. Next, speaking on medication errors and liabilities, we have one of our favorites, Paul Lefebvre. All right.
Thank you, Josh. My name is Paul Lefebvre. I am a lead claims professional and risk advisor for Preferred Physicians Medical. And according to Toni's chart, unless Yvonne is a member of Congress, I'm the least trustworthy person on this panel. So I'm going to try to share some information and cautionary tales today. We are a Preferred Physicians Medical is a anesthesia specific professional liability carrier. We insure anesthesia professionals and practices all across the country. I do not have any conflicts of interest to disclose. It's a privilege to be invited to speak on this panel, just a few miles away from where the APSF was founded almost 40 years ago. Around that time, new monitoring technologies like pulse ox and capnography were introduced. The closed claims study was launched. Simulation-based training was introduced. The ASA adopted national standards for basic monitoring. You might consider our company a byproduct of the founding of the APSF and the advancements that followed. In 1987, PPM was founded by an anesthesiologist who, like the folks at Harvard and Crico, anticipated that intraoperative complications, often attributed to anesthesia, would be far less likely to occur. So he founded our company, and the basic monitoring standards are actually part of our policy, and they have been since our inception. He and the other pioneers from the APSF were right. Safer medicine did lead to fewer claims and lawsuits, and liability insurance premiums for anesthesia professionals decreased significantly. Throughout the next few decades, numerous initiatives spearheaded by the APSF advanced patient safety and helped prevent avoidable harm. We've seen this in our historical loss data. Our claims history also reflects that medication error prevention has proven to be one of the most challenging problems the anesthesia community has endeavored to solve. In a few minutes, I'll share some of our loss data and patient safety strategies to prevent medication errors. But first, I want to start with a case study. This was a file I handled a few years ago to highlight a very concerning loss trend we've recently identified involving a particular type of medication error. This won't be the first time that we've heard about these. So this case involved a 60-year-old male who presented to a critical access hospital, 25 beds, for left hip arthroplasty. The anesthesia plan was for a spinal. The patient was transferred from the pre-op area to the operating room where the spinal was performed. Our insured, the anesthesiologist, removed what she believed to be mepivacaine from the tray in her anesthesia cart. An important detail is that this group covered 2 hospitals. The anesthesiologist was typically at the other facility, and she was assigned to this one on the schedule to cover for a colleague who was on vacation. So it was a little bit of an unfamiliar environment. The health system had also just contracted with a new vendor for procuring medications. And this was her second case of the day, but when she had her first case, she noticed that there used to be a red cap on the TXA and a blue on the local, but that they were both blue. So she thought to herself, oh, I need to be careful. And she went ahead and handled the first case for the day. This was the second case. So due to the patient's body habitus, it was a little unusual and had some trouble placing the block initially. So when the patient reported some lower back pain and itching on his backside, she elected to convert the case to general anesthesia, assuming that this was just a failed block. Shortly after surgery start time, the anesthesiologist and surgeon observed some clonic movements. I can only imagine the sinking feeling that she felt in the pit of her stomach as it dawned on her that maybe she'd grabbed the wrong vial with the blue lid. She went over to check the sharp spin and realized that she discarded the TXA after administering the spinal. She contacted her partner, one of the heads of the group, to let him know about what had just transpired. And he immediately started looking up interventions, an appropriate way to manage the complication. And then he got in his car and headed over to this facility to assist. They performed a CSF lavage. They drained off 30 cc's of cerebral spinal fluid. And as they were replacing it with sterile saline, they got about between 5 and 10 milliliters, and the patient started having some movement again. So they stopped and waited until they'd be able to transfer the patient to the ICU. He remained sedated and was transferred to a higher acuity hospital a few days later. Now, after the patient had left the OR to go to the ICU at the first facility, that's when our insured contacted our office. One of the hardest phone calls, part of our job, is oftentimes we talk to anesthesia professionals on the hardest days of their job, and this was certainly one of mine. She was devastated. She's a terrific clinician. She was a leader in the group. She was kind of their patient safety advocate. When we'd done risk management programs and things like that, it was clear that she was a leader, and it was tragic that this was happening to her as well. So that was a tough call, but she had some questions about documentation. She had some questions about conversation. How do I disclose this? Can I go out and talk to the patient's wife? And of course, this was a situation where it was a clear error. It was confirmed. There wasn't any investigation that needed to take place. So I obviously encouraged her to do what was right, what was human under the circumstances, and go out and apologize and explain what had transpired. This is one of 38 states that has what we call apology laws or apology protections, protecting benevolent gestures, sympathetic gestures from being discoverable during the course of litigation. But in the other states that don't have those, we're just going to offer our policyholders the same advice under the circumstances. I'm not aware of us ever having a case that hinged on whether or not the anesthesiologist or the CRNA or the AAC went out and apologized and conveyed their sympathy, whether it's a known risk and complication or whether it's a clear error. And Toni, it's hard to define error, I suppose, in the legal context. We look at these through the lens of whether or not there was a departure from the standard of care. Best I could probably do is that this is a preventable harm that is indefensible from a standard of care standpoint. And when the documentation question came up, she asked about also, is it okay to put error in the record? And of course, we didn't need to get a thesaurus out. It wasn't going to keep us out of litigation if that was what the patient was going to pursue, or in the interest of resolving it once we knew the nature and extent of the patient's injury. So obviously I encouraged her to do that as well, which she did. The patient remained sedated. He was transferred to the other facility. He emerged and was extubated on post-op day 4. This is by far the biggest outlier of all these cases that we have. This patient went on to make a remarkable recovery. He was discharged on post-op day 8. This was during COVID. So instead of sending him to a rehabilitation hospital, he did his PT. He treated with a neurologist, treated with a rehab medicine specialist from home. And over the course of the next 6 to 8 weeks, he really made what the neurologist described as a remarkable recovery. His biggest injury was some pain in a cervical pain, and that was likely from seizures or positioning when he was in the intensive care unit. So notwithstanding his outcome, obviously, the patient and his wife filed a lawsuit against the anesthesiologist, the anesthesia group, and the facilities. We mediated this case. This was within 9 months of the event transpiring. So this was a case that we knew we should resolve quickly, get together with the parties, and we did that immediately after the case was filed, actually. And it settled on behalf of the anesthesiologist, the group, and the facility for within our policy limits, and the hospital contributed 20%. So these are a few remedial measures that were implemented in the wake of this. They got together, they did peer review, quality review. And these were some of the solutions that they came up with. It was that local anesthetics used for spinal should be checked by a second person prior to administration. TXA should not be stored in close proximity to local anesthetics. The anesthesia group, and this wasn't our first TXA bupivacaine mix-up case. We encourage them to also coordinate with pharmacy, and I'll get to this in a little while, but about having TXA prepared in pre-filled bags. And I'd also mention that on the second day after this event happened, the anesthesiologist kept in touch with the spouse, and they spoke often in the immediate recovery period. And she mentioned that she hoped that someday that the story could be told as well, so that to avoid this type of harm happening to somebody else. So I'm happy that we're able to do that today. So here's a few other examples of medication error cases that we've seen. Overdoses, whether that's due to wrong dosages that are being administered in the facilities, or I guess overdose isn't the correct word as far as some of the opioid-induced respiratory depression, but we've seen some of those cases certainly over the years. Thanks to the work of people like Yvonne and organizations like the APSF, we've seen fewer of the opioid-induced respiratory depression cases at home, but there's certainly still work to do, and one is too many. Medication vial mix-ups continue to be our largest area of exposure. Here's just a few examples. We did have a neostigmine, neosynephrine mix-up as well recently, and my colleague actually had a call yesterday about another medication error that came in. On the also known drug allergies, sometimes that's attributed to issues navigating the EMR, workflow. There was one instance that came to mind as Dr. Vincent was talking that we had a insured report a sentinel event at an ambulatory surgery center involving loss of an airway. And 2 days later, he called back and said that it was a Friday morning case and the patient had a known allergy to a local anesthetic, and he overlooked it in the record. And there was a component, I think, of getting back to work, and that was a tragic outcome for the second patient as well. So I think that's an example of facilities also maybe getting together with the clinicians that are there to support them and make sure that they have the resources they need before they return to work. Medication, so here are some common causes and allegations, and I stress allegations. These are the ways that cases are presented or prosecuted against our insured. So obviously a momentary lapse in concentration or situational awareness, that's more an allegation than some of the investigations that would reveal. So systems issues continue to be one of the most prevalent causes, and we've talked about lots of these this morning. I wanted to share some of our company's loss data. The 236 number I thought was pretty high until this morning when I saw the poll. So either we insure the luckiest 6,500 anesthesia professionals in the history of the world, or these are being underreported to us. So that's in the last 37 years, we've had 236 medication error adverse events reported to us. 79 resulted in a claim or lawsuit, and indemnity paid has exceeded $17 million. Defense costs are approaching $4 million. We have moderate severity files, 21 of those for just over $100,000 in what we call indemnity, which would be the settlement or judgment if it went to trial, which obviously for the reasons I mentioned, these do not. The most concerning trend that we've identified is these cases that are resolving for significant amount of money. And I don't use that in the context of narrowing things down or reducing things to dollars. What we would call claim severity is a reflection of the harm that the patients are experiencing. And that is what brings us to the concerning trend and the particular type of administration error. So we now have 9 tranexamic TXA mix-ups that have been reported to our company. When I got together and had the opportunity to write an article with Dr. Rebello and Dr. Jew and Angie, Lindsay, and Tricia Meyer, I think we were at 5 or 6 at that time. So we've had 3 over this summer, and I most recently took a similar call 3 weeks ago. So these are continuing to occur and in fact are occurring more frequently than they did in the past. So those 4 cases have settled for over $6 million, which represents 35% of all of our company's historical medication error losses. And that does not include the 5 that have been reported and not yet turned into claims or resolved. So to illustrate some of this, I just wanted to break down, this is the last 3 decades as far as our medication error. This is the indemnity payments. So again, to reflect the frequency and severity of the claims that we're seeing. And you can already see that we're exceeding the prior 2 decades. And this does not include those cases that have not been resolved yet. So we do what's called reserving, where we set aside money in anticipation of resolving those claims in the future. And when we add that on, this is what we're looking at for this decade. And this is almost entirely driven by the tranexamic acid bupivacaine mix-up, wrong route, medication errors. So we will be about 3-fold what we were from 2005 to 2014, we anticipate. Dr. Ward, don't throw tomatoes at me. I'm sorry about the read the label carefully. The ISMP's hierarchy for effectiveness of risk reduction strategies is an effective lens to use some of these through. And while education and warnings are the least productive and the lowest leverage, we've got lots of policyholders around the country that when we go around and we share these presentations and slides with them, they do an eye roll when we talk about barcode scanners and things like that, because they're in critical access hospitals or ambulatory surgery centers or doing office-based anesthesia. And those simply aren't things that are made available at those facilities. So I hope that we're working towards that. The technology, culture, and collaboration strategies, these are all born out of the last Stoelting conference on this topic. There's been some wonderful technological advances that have and will drive change in the right direction. And embracing a culture of safety, patient safety is obviously important as well. Encourage the reporting of near misses at your facilities. If the technology you're asked to use doesn't fit workflow needs and patient safety, let the administration or department heads know. Make sure everybody is kept in the loop when drug shortages arise or when the facility changes drug vendors. If vials aren't stocked in the right place, make sure it's brought to the attention of the tech or the responsible department. And lastly, collaborate with pharmacy if that's an option at your facility, or get ready to administer products that can be used in the OR. If practical, ask them to do pre-filled syringes and reconstitute medications. This is really the key intervention for these particular medication errors. This is the high leverage risk reduction strategy the anesthesia community needs to get behind for the TXA bupivacaine mix-ups. I appreciate that my experience and perspective is different from the clinicians in this room. Yesterday, I had an opportunity to tour the Ether Dome. That was, if I can count that as an operating room, that was the 3rd operating room I've ever been in. So my experience is obviously very different from everybody here. So I'm always very mindful of advocating for a particular action at the exclusion of others, since I can't fully appreciate how implementation will work in your facilities and what the collateral consequences or events that stem from it could be. That's why I was elated when we were working on the article and Dr. Rebello and Dr. Jew and Dr. Meyer all we got towards the end, and I can't remember who it was, but the email went through. It said, "No, we got to get behind ready to administer products." We've tried some of the other things. These medication errors, this particular one cannot continue to occur. We have one solution that would solve the problem. So, as stated in the article's conclusion, the costs and resources required to bring about this change are inconsequential when you measure them against the harm that the errors occur or that the errors cause. The time to act is now. Thank you.
Paul, thank you so much. If you come shadow me in the OR, do I get to go spend some time in the courtroom with you? All right, next we have, oh, no, wrong one. My apologies. Was it? You got it. Oh, good. Oh, I read this one out here. All right, next we have our beloved Dr. Steve Greenberg, who's talking about the criminalization of medical errors, the APSF response.
Thanks, Josh. Before we start, I'd like everybody just to stand up and get a stretch. I'm seeing more and more people are moving to the back, and that's a sign we got to kind of get the blood flowing. So before I speak, let's just speak about something that's pretty, a little bit dark. That I'd like you guys to kind of do a little stretch. All right. So I want to just introduce myself. For those of you who don't know me, I'm Stephen Greenberg. I have the honor and privilege of serving as the current APSF Vice President. Let's see here. Where is the advance keyboard? Second. Okay. There are my disclosures. None of the investigative initiate grants I'll be speaking about today. And here are my objectives. I'm going to define medical and medication errors, something we actually have not done yet today. I'm going to discuss the APSF's activity on medication errors, discuss the historical and global perspective of criminalization of medical error, and then describe the unintended consequences of criminalization of error and discuss the APSF response on criminalization of error. So, what is a medical error? According to the Institute of Medicine, it's the failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. Medication errors, according to WHO, any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in the control of a healthcare professional, a patient, or even a consumer. So that's what we're talking about. And we've gone through this through the last several hours. Medication errors are one of the most common medical error. You know the cost. I think something that really strikes me is that 1 in every 20 perioperative anesthetics delivered can result in a medication error. How many of you are anesthesia professionals? Just raise your hand. Okay, that means at least once a day or every other day, we're seeing or we're actually involved with a medication error. That is just unacceptable. We have to make change. We know that substitution error is the most common error, and 4% of all anesthesia closed claims database are medication error related. We know, and you'll hear throughout this brief discussion, anesthesia departments should create a culture of no blame so that everybody can speak up against these patient safety threats. And I do believe barcode scanning has been shown to decrease medication errors. So this is not new to the APSF or its newsletter. In fact, in 1987, 40 years ago, nearly, the winter issue, and I quote, "Mother dies when given 2 ampules of adrenaline in mistake for Pitocin." That was in 1987. You just heard Mr. Lefebvre talk about an article we just published a few months back in the newsletter, mistake when giving TXA in the subarachnoid space when it was meant to be given for bupivacaine. So again, this problem is not new. And the APSF thinks this is such an important problem that we actually dedicate part of our website so that all of you and our entire global constituency can write into us with these look-alike files so we can post them and send them out via our newsletter, our website, and our social media platforms. So hopefully you don't make those same errors. This is our 3rd conference on medication safety. You've heard that throughout the day. We had one in 2010, and there we actually developed the STPC acronym, which stands for standardization, things what we've talked about ad nauseum today and in previous meetings, technology, identifying medications, training, mandatory safety checklists, pharmacy, collaborating across lines with pharmacy and standardizing pre-prepared meds, and then enhancing and creating a just culture for all of our hospital systems. But we repeated this in 2018. We talked about drug safety, promoting safer anesthetics for our patients, reducing administration errors, drug shortages. We had a great conversation this morning about it, but we need to simplify ordering and establish contingency plans. And lastly, and very importantly, standardization and innovation collaborate across specialties. It's not just about anesthesia, it's about everybody who works in the perioperative space that we have to get to the table to make change. Well, despite our efforts, and you've heard all and seen all of these newspaper clips, the third leading cause of death in the United States is medical errors. And according to one report, 1 in 10 patients who walk into a hospital are harmed by a medical error. 50% of those are preventable, just unacceptable. Interestingly enough, criminalization of medical error is nothing new. I'm gonna spend a few minutes talking about these cases that span over a 30-year period of time. Start in 1990, a nursing home physician in New York accidentally or actually ordered tube feeds to be administered into a peritoneal dialysis catheter, which caused chemical peritonitis and a patient's death after they failed to transfer the patient to the appropriate hospital care. That physician was charged with reckless endangerment. Next case, in 1990, late 1990s, we had 3 Denver nurses who were taking care of a newborn and accidentally gave them a 10-time increased dose of penicillin in the IV space versus intramuscular, which caused that child to die. Unacceptable, reckless homicide. Next case, nurse in Madison, Wisconsin, place that's near and dear to my heart, hooked up an epidural anesthetic with bupivacaine to an IV that resulted in a teenage parturient's death. Again, another unfortunate charge of negligent homicide. And lastly, and sadly, a 2-year-old girl who was undergoing chemotherapy at the time when the pharmacist mixed that chemotherapy in 23.4% saline versus normal saline, which resulted in this child's death. Simply unacceptable, but this is nothing new. However, this is also nothing new to the global community. There are reports throughout the literature and newspaper showing that surgeons, anesthesiologists, other anesthesia professionals, trainees, primary care physicians are charged with jail time, probation, overturned convictions, drop charges, and not guilty verdicts in Japan, Australia, Great Britain, China, and even Canada. So this is a global problem. So what was really the catalyst for a call to action for many of the organizations you represent, including the APSF? Well, it was the case in 2017, and I'm not going to go through all the specifics, but it was a Tennessee nurse who accidentally administered vecuronium when she meant to give Versed or midazolam to a patient that resulted in a patient's death. And if you look at this long list of distractions and errors, if we take 1 or 2 of these out of the list, that patient might have survived, and we might have not had all the catastrophic events that have occurred in this particular case. But that promoted many organizations to start thinking about this, developing position statements and action plans. But I want to remind everybody that criminalization of error has tremendous unintended consequences for healthcare. So we start with criminal charges of a healthcare provider. What does that do? That produces fear of the loss of livelihood for all healthcare professionals. And then it also sends a message that healthcare professionals have to be and should be perfect, which we know none of us in the world are, let alone healthcare professionals. Then what happens is the current healthcare professionals leave the profession. There's increased civil litigation. There are significant shortages of healthcare providers. So now we build upon the COVID pandemic. We have loss of great healthcare professionals, and also promotes defensive medicine and unnecessary testing, which then leads to unsafe conditions and a decrease in healthcare access, all leading to patient harm. So this is not the answer. Well, a lot of the societies that many of us are a part of came out against the criminalization of medical error when not intended. And I'm not going to go through all their specific statements because I'm going to turn the page on what we did as the APSF organization. What we did is we got together a multi-professional, multidisciplinary group of folks that included attorneys, CRNAs, anesthesiologists, intensivists, pharmacists, surgeons, patient safety advocates, and patient safety scientists to figure out what we were going to do, what kind of statement we were going to develop with regards to the criminalization of medical error. So we published the position statement in the October 2022 APSF newsletter. And first and foremost, we believe that criminal prosecution provides no comprehensive mechanism for exploring the underlying causes of patient harm. However, we thought it was appropriate to discuss when it's appropriate to prosecute healthcare professionals. Number one, when those professionals engage in a pattern of continuous reckless behavior. Number two, when they commit errors that lead to harm while under the influence of substances that impair their performance. And then number three, when they actually intend to harm. And believe it or not, we all know cases in the literature and in the newspapers of where unfortunately healthcare professionals do intend to harm. And by definition, this is not an error. We also wanted to talk about what healthcare organizations should do to mitigate medication errors. Number one, we should employ medication safety techniques that we're all discussing today in technologies. We should operate on the principles of just culture. Again, where every single one of us has a voice at the table to recognize threats and then do something about it so that the next patient does not get harmed. Disclose to the appropriate authorities. Develop a multidisciplinary medication safety committee. I'm going to stop really quick because the last 2018 meeting that I attended to at the APSF, I came home to my own institution and I found out we didn't have a perioperative medication safety committee. So I started one. I started ones with pharmacists, nurses, legal risk managers, pharmacists, everybody you could possibly, surgeons, get us together and figure out what we can do to eliminate or reduce error. And I'm proud to say that today we've developed over 2.5 dozen interventions that have either eliminated medication errors in certain areas or reduced them substantially. And we were just recognized last week from the Magnet survey for being a quality multidisciplinary committee that has actually made change. So that you can actually do these things in your own hospitals and communities, and it's not that difficult. And then ensure compassionate treatment for those that have not only the error, but also the second victim. What should healthcare professionals do? Well, I think it's time. We've always talked about it, but we need to make sure that we look at the dispensing of methods for high-risk drugs. We only should use override methods when urgent and emergent situations arise. And when we do that, we should institute a double verification system. We've done that in our own institution on every single subarachnoid block placement. There are 2 healthcare professionals that have to look at the vial, make sure it's preservative-free, make sure that there's no expiration, and it's the right dose, right patient, and the right concentration. So we really need to work together to do that. We need to ensure appropriate monitoring of patients receiving high alert drugs. We don't need to contribute to normalization of deviance, and we have to empower all of us and others to speak up when we see these threats. So what's the APSF going to do? Well, if this happens to a healthcare professional who did not mean to make an error, we're going to learn about the circumstances. We're going to make public statements about the harm of unreasonable retribution for medical error, reporting to patient safety, and we're actually going to provide information to prosecution about system issues and harm that would be done by prosecuting healthcare professionals who intended no harm and had helpful intent. And then finally, we're going to provide comfort to that healthcare professional. Lastly, the APSF's intention is to foster patient safety by making public statements about efforts by organizations and governments that you all represent to improve patient safety. We're going to make best practices available like we have on the APSF newsletter, our website, social media. And we're going to inform patients about what questions and what answers we might be able to provide them in terms of safety in the perioperative space. And we recently developed a website in that aspect, and it's actually developed a significant amount of page views. We're working collaboratively with professional organizations and advocacy groups to enhance awareness of medical errors and systems, to identify and implement best solutions. And yes, of course, you are now at our 3rd consensus conference on this medication safety process. So I want to leave you all with this idea. We need to make sustainable change. I heard somebody earlier say we might need to even think about mandating it, but we have the necessary brain power in this room to make a difference, get together, talk across organizations and across individual hospital systems and industry to make the necessary change that will allow our patients to have a safer environment and the providers that also suffer from these type of errors. We're great at spreading knowledge. Now it's the time to work together to make the change at the bedside. I appreciate everybody. Thank you for participating in this great conference.
All right, thank you. Thank you all to our speakers. Now, after we've learned these insights, I want to open up the floor for questions.
Don't be shy.
Our mic to the right.
Thank you. My question's for Dr. Milburn. I enjoyed your presentation. It is my guess or belief that there is a dearth of knowledge and of research, published research, on the topic of the trainees' experience in medication and other types of errors in the perioperative period. Do you agree? And do you think that an effort should be made to promote research for trainees in this area?
Yes, absolutely. So in preparing for this talk, there were a few different approaches that I was going to take. And looking at the literature first, there isn't much literature published in anesthesiology specifically about medication errors, whereas I feel like our specialty is one of the most prone to it, given our easy access. So I definitely think that there's a need for increased research in medication errors with trainees and would be happy to contribute. Thank you.
Dr. Cole.
Yeah, a comment and a question. First, the comment is for Yvonne. I first heard her story about 1.5 years ago, and it was a tearjerker then, and it's a tearjerker now. I mean, I do not think you can be a human being, listen to that story and not have it touch your heart and motivate our souls to go back into our own institutions and do a better job. So thank you for your courage. You have saved a life and hopefully many lives. The question regards a silent epidemic. That's a term that's not necessarily known to a lot of us, called administrative harm. And there's a number of people on the panel that could address this, or administrative decisions that result in adverse effects to patients and the workforce. And it's not just the people in the C-suite, but there's several layers of administrators and people, us, the caregivers, that put together systems and cultures that are not right, and they actually, induce harm. I would be interested in the comments of maybe Toni, Amy, or even Steve about how we address this, call it out, and fix it. It's not easy, but I think it's not a familiar concept.
So I'm going to take the first crack at this. Are you referring to the administrative burden of our job?
No, the administrative harm. So decisions made by administrators, and I use that term loosely, not just the C-suite, but it could be us, that put in together systems and cultures that result in adverse effects to patients. If somebody brought up production pressures, that is a system, a culture that results in adverse events.
I will say that one of those, a big aspect of that to me is a breakdown in communication from what I call the clipboard people and the stethoscope people. And both groups bring a very specific skill set to the table, administrators and frontline clinicians who actually touch patients. And there is certainly a breakdown in respect and a breakdown in communication between the two groups for a number of reasons. Part of our recommendations from the ASA's Committee on Wellbeing in terms of creating just cultures of support in the workplace, not just cultures, but cultures where people feel support in all the myriad ways that means to each individual, is that there are open lines of communication between those two groups, such that there's also psychological safety. People have a mechanism, a way to provide feedback back to leadership, whether that is because of their sparkling and open personality, or it's because you have anonymous comment boxes. It requires multiple modes of conversation, but it also requires of leadership a certain level of transparency and accountability to rigorously respond to that feedback, to invite it, to be open to hearing it, because we all have blind spots. So, from our perspective, that administrative injury occurs when there is a breakdown in alignment between in understanding of both the I'll say corporate mission and the clinical mission. The closer we can get to psychological safety and having those two groups openly communicating with one another, the better we're going to be. I don't know if that comes close to addressing what you're looking at.
Thank you.
I can speak to. Okay, I can speak to that. When I recently returned to a clinical position, I had to make sure that where I was going to practice aligned with my personal mission. I am grateful that I live in a city where it's rich in healthcare systems, but I sometimes have to decide where I'm going to practice, who I'm going to answer to, and what the mission of the organization is, and make sure that it aligns with my personal mission. And sometimes that's not the best place to work, but it's the right place for me.
Yep, I think I would take a little bit different approach. I think if you're going to get the resources you need to avoid what you're talking about, Dan, we all have to be proactive. We also have to have some responsibility on the clinician side to kind of bridge the gap between clinicians and administration. And I mean, one of the things, and no place is perfect, but a lot of our folks are involved with administrative aspects in the hospital. And why is that important? Because we are not just delivering perioperative anesthesia care, which is very important, most important thing, but we're actually developing relationships that open that dialogue of communication that you're talking about, Amy, with regards to what really matters. Get them to see that your great ideas are their ideas. Then we all are successful, and particularly our patients. So I think it's really incumbent on us to take a little bit different approach rather than an antagonizing relationship. Try to find pathways where we can bond, be more proactive, get involved in your community or academic hospitals in one way or another. And then you'll make those relationships hopefully work for the patients and yourselves as providers. That's what I think. And again, that's a huge leap because there are a lot of ineffective relationships in hospital administration and in the clinician relationship. But I think that has to be a start. We have to go out and seek those relationships and be apparent and visible within our hospital systems.
I'll just add, we also need to sponsor the time for people to do that, especially during all the staffing shortages we're having. This is not free work that's being done. I mean, this is the volunteer hours of overextended clinicians. So we need to support that as well.
I think we have time for one more question.
I'd like to address this question to Paul. When you described the first case you mentioned an apology, the importance of an apology. Another concern that patients have when an adverse event occurs, whether it's drug event or whatever, is they don't get told what the problem was. And the major reason for initiating lawsuits, I think, has been the fact that patients don't find out what happened until they initiate a lawsuit. And then that takes years. In the late 90s, the University of Michigan healthcare system initiated
not only an apology, but a detailed analysis of these events that occurred in their system. They developed a rapid response to events that clearly were at fault, and eliminated the need for lawsuits, apologized, and paid a settlement that was agreed upon. Those that were clearly not their fault from their perspective, they would fight to the very end. And then there was the middle group, which usually involved rapid settlements of lower amounts. Excuse me. The end result was that the insurance company saved millions of dollars. In fact, they saved so much that the state of Michigan laws required them to return about 2/3 of their reserves. Some people in the room are probably familiar with this. I know in the University of Illinois in Chicago adopted this. Do you have experience with this? And if you do, could you describe how it works with, or how you think about it anyway in this regard?
Sure. So our experience is more in relation to some of the states that have passed candor laws. So there's Colorado, Utah, Iowa,
Massachusetts.
And Massachusetts has one as well. So in the states that do provide that mechanism, and it's protected, it's kind of like some states have pre-lit screening panel process where information that's more adversarial, but we've had mixed results. But oftentimes in a situation where we have a medication error or an OR fire or a case where it's a clear case of liability, there's not much finger pointing amongst the clinicians. The facility, who maybe bears some responsibility as well, isn't trying to point the finger at other parties and things like that. Under those circumstances, we participated in those programs, and they haven't necessarily been productive in the handful of instances that I had. I can give an example. We had participated in this program in Utah. It was probably about 18 months ago, and it involved a surgeon who was supposed to be on call and missed, they tried to reach him throughout the night, and essentially the patient's condition deteriorated. Our insured got there at 6, did an anesthesia eval, went to see him. He was really in rough shape. Got on the phone, tried to maybe get him transferred to a different facility so that he could undergo surgery faster. We participated in that. We're available to the family. I think it was helpful for them to understand who was involved in that particular case, and they elected not to pursue litigation against our insured after that meeting. Now, after the first discovery disclosure, so they pursued the facility and the surgeon. The surgeon filed a standard, or the surgeon's attorney filed standard non-party at fault affirmative defenses. And ultimately, they ended up adding us into the case. So we are defendants in that case now. And it wasn't because of the family or anything like that. It was, in this instance, it was a co-defendant. So I think that in a large health system with a captive insurance where you have the facility and all the doctors and nurses, everybody's kind of under the same umbrella, and the investigation can be comprehensive and uniform. The institutional ones, and I can't speak to them from our experience as a private professional liability carrier, but I can certainly see how those can be productive. Now, on our end of things, I think that when we recognize in the case of medication error, we did not delay. We knew what information we needed to determine the nature and extent of the patient's injuries, the medical expenses, the out-of-pocket. This happened to be in a state that had a cap on non-economic damages, so that made it easier to resolve the case as well, because obviously it was a cap case all day long on the non-economic damages front. So it's just a matter of getting together and getting the case resolved. And that was a state that didn't have candor, and we wrapped it up just as fast as that Utah case even got to that process. So I think that mixed so far.
I just wanted to add that the ENT that operated on my son, he tried to contact us immediately after he had heard of the death of my son, but I didn't get the message for a week because life stops. I mean, at that point when you have a death, I mean, I'm sure you guys have experienced that, but it was like a week later after the funeral, after all the family had went home. I was going through my phone messages and I had a message from the surgeon. And he had said, you know, if you need to talk about this, call me. It was 11:35 at night and I called him and he answered his phone. And he answered the questions that I had, you know, could this have been, you know, his fault surgically or whatever? And he had already spoken with the coroner. The coroner had called him because he was the attending physician and explained the findings of the thing. And so it made a big difference to me that he had reached out to me. And he worked with us the whole process. We did legislation to try and correct this error in the Utah hospitals, just for education wise, that this is a thing that happens. And he was right there standing behind us the whole time. Once we finally got the coroner's report, my daughter-in-law and I were able to go to his office and he went through everything to help us understand as just a layman, what the medical terms meant and what the findings were. And that was very helpful for us. We didn't sue or anything like that. He was our friend and we understand things like that happen. And there was no fault on his part, but to me, it was comforting just that he would reach out to us and help us understand what had happened since we didn't know that.
I want to thank Josh, Yvonne, Toni, Amy, Amanda, Paul, and Steve. This has been such an important session for all of us. I want to thank you for sharing your stories, exposing your vulnerabilities. And, you know, really, I feel like in this room, there's just an element of humanity that's just been created, you know, and really when we share this, we really bring a part of ourselves, not only to what we do, but to those that we take care of and those in our families and beyond. I just want to thank you for sharing your stories. Really, really appreciate it. This is a good time for a break. So we're going to take a break. We'll gather again at 3:00. Yeah. For those of you that parked in the MGB garage, please see Stacy. There are parking vouchers available.